This section is on chronic obstructive pulmonary disease, COPD, and also asthma. As we start to talk about COPD, I want us to look at this little cartoon-like figure here. A major risk factor for COPD is smoking. And I love this guy with his barrel chest. As you recall, one of the major manifestations of advanced COPD is a barrel chest, an increased anterior-posterior diameter. So I just couldn't resist this. If you insist on smoking today, you can plan on having a barrel chest in the future. As we start to talk about COPD, we know that these are respiratory conditions that produce obstruction of airflow. And the ones that we're going to look at are emphysema, chronic bronchitis, and bronchiectasis. We'll look at asthma separately in a few minutes. This is just a little review, if you will, of some anatomy here. And you can see the trachea, and then your main stem bronchi. And then we have the bronchioles. And if we look at this little cutout section here, here's your little bronchiole. And the alveoli, this little cluster of almost grape-like things here, the alveoli are where the O2-CO2 exchange takes place. The alveoli are little air sacs out there, and they are surrounded by blood vessels that will give up CO2 and pick up O2. So this is that was just a picture of the respiratory tree. Now what we're going to do is to look first at the different diagnoses and the pathophysiology, and then we'll talk about the nursing care together, because the nursing care is pretty similar for several of these conditions. First, I want us to look at emphysema. We define emphysema as a chronic disease with excessive inflation of the air spaces distal to the terminal bronchioles, alveolar ducts, and alveoli. There is an increased airway resistance and a decreased diffusing capacity. Now, if you take a look first at this normal side over here, and I've colored these alveoli green in this picture, and you can see the blood vessels around them. And they will pick up the O2 and give off CO2. So they pick up O2 and give off CO2. Now on this side we have emphysema alveoli. The first thing you might notice is that the walls between them are broken down. So they're overdistended, and these walls between them are broken down. You may notice that there's fewer total red lines over here. So that means that there is less diffusing capacity. There's less blood vessels there to pick up the O2 and give up the CO2. These rather irregularly shaped areas here, these alveoli that have had the walls between them broken down, have lost their elasticity. Your alveoli have a little bit of elasticity, and that elasticity kind of allows the air to be pushed out. And they've lost that. They don't have that elasticity anymore. So CO2 tends to accumulate in those overdistended alveoli. Also, we tend to get an accumulation of mucus and secretions that will collect in there as well. So that's what's going on with emphysema. Now I'd like to think about chronic bronchitis. And if we look at the picture with chronic bronchitis, you can see the definition says there's an excessive mucus production with a cough for at least 3 months a year for 2 successive years. Now if you look in these bronchi, here's the normal bronchi, and over here it's full of stuff, of mucus, nasty stuff in here. And so these patients are always coughing and spitting. And if you look at every picture that you'll ever see of someone with chronic bronchitis, you'll notice that they've got a handkerchief in their hand. And if they have a handkerchief, that's because they're always spitting. Cough, spit, cough, spit. That's what they're doing constantly with chronic bronchitis. And the third of the diseases I want us to look at is bronchiectasis. Bronchiectasis, by definition, is chronic abnormal dilation of the bronchi and destruction of the bronchial walls. This is probably the least common and the least likely to show up on NCLEX. I think simply knowing the definition will be sufficient for that. Now, patients who have chronic lung disease, one of the things that they're going to need are bronchodilators. So almost all of these patients will have some type of bronchodilators. Your aminophelins, your epinephrines that are bronchodilators. Mucolytics or expectorants would be a part of their management. That's to make their secretions loose and make them able to cough up their secretions. Sometimes they will get steroids. These are usually for short-term use only. Sometimes we say we want to clear them up with steroids. You might also see antibiotics being prescribed for them. Again, that is a short-term use for secondary infections. They're not always going to be on antibiotics. It just tends to seem that way. Now, if a patient has a chronic lung disease, you want to teach them, first and foremost, don't smoke. So you teach them to stop smoking. And that's probably the hardest thing of all to do, is to teach them to stop smoking. Another thing you'll need to teach the patient is pursed lip breathing. Pursed lip breathing is when they're going to be breathing in through the nose and then breathing out through the mouth like they're blowing out a candle. So, pursed lip breathing. This allows for a more prolonged expiratory phase, so they can get rid of more of the CO2 that's building up in their system. Some patients will have learned how to do it, others will be teaching the patients how to do it. The patient with COPD will also be a diaphragmatic breather. This means that he breathes with his diaphragm, and he can't use some of those accessory muscles as well. Now, when you have eaten a Thanksgiving dinner or a feast type of dinner, at the end of the meal, you sometimes push back from the table and you said, I ate so much I can hardly breathe. That's because your tummy is so full that it's pressing up on the diaphragm and making it hard to breathe. With a patient who has COPD, feast days, Thanksgiving Day, is very difficult for them, because if their tummy gets so full and it pushes up on their diaphragm and they can hardly breathe, they don't have the other ways of breathing that most of us do. So they need to eat very small, frequent meals because of their diaphragmatic breathing. We need to encourage lots of fluids for patients who have COPD. And the reason we need to give them lots of fluids is this is a mucolytic agent. The very best mucolytic agent of all is water. Now, can you think of any time in the care of someone with COPD when you might not want to give them lots of fluids? That's right, you wouldn't want to do it when they go into heart failure. And many of these patients will go into right-sided heart failure, and then you might not be able to give them lots of fluids. Now, patients with COPD will also need oxygen, usually at low levels. It's also important that these patients get flu shots and pneumonia vaccines, because they are at high risk for respiratory infections, and sometimes these infections can be fatal for the patient. Let's do a question. The nurse is caring for a patient who is admitted with severe COPD. The nurse enters the room and notices that a family member has set the oxygen to 10 liters per minute. What is the best immediate action for the nurse? 1. Assess the patient's skin color. 2. Take the patient's vital signs. 3. Turn the oxygen to 3 liters per minute. Or 4. Notify the physician. And the best action here is number 3. Turn the oxygen to 3 liters per minute. Now, what happens here is that the normal stimulus to breathe is a high CO2. So I don't have COPD. I would expect that my stimulus to breathe is a high CO2. When my CO2 levels get high, the brain says, hey, why don't you take a deep breath and breathe? And I do. In COPD patients, their CO2 levels are always high, so their stimulus to breathe becomes a low oxygen level. Now, if you were to give high oxygen concentrations to a client with COPD, what would happen is those O2 levels would be raised above the threshold and they would no longer breathe. So it's very dangerous to give high O2 levels to patients with COPD. Usually it's at 2 or 3 liters, not more than 4 liters is what we're going to be giving people who have COPD. Now, I want us to talk for a moment about asthma. We're pulling out asthma and looking at it separately. If we look at the physiology of asthma, we see an increased bronchial reactivity to various stimuli, which produces episodic bronchospasm with airway obstruction and excessive mucus. So if you take a look at this picture here, and you see here is the bronchiole, and then just look at it with these bands all tight around it. And that's what happens. This bronchiole gets so tight, you get bronchospasm, and then you get excessive mucus production. And the combination of this two is what we call asthma. So and the patient wheezes. In a patient with severe asthma, you don't need a stethoscope to hear the wheezing. You can hear them wheeze across the room. Is asthma a serious condition? Oh yes, asthma can be life-threatening in uncontrolled asthma attacks. So it's a very serious condition. Now, what are the stimuli that cause an asthma attack? It varies. The stimuli can be anything from environmental stimuli, so dust in the environment, other kinds of pollutants in the environment. It can be animal dander. It can be sometimes emotions, and all the hormones and chemicals triggered by emotions can do it. Sometimes heat can do it. Sometimes exercise can do it. There's a whole host of things that can trigger asthma attacks. Now, when a patient has an asthma attack, we need some quick relief meds. So quick relief meds, things that are going to act very quickly, and they last just a few hours. Albuterol is a common one. This Atrovent is another fairly common one that might be used. Oral and IV steroids can be given for quick relief. And that can be used during an acute asthma attack. Some of these are given inhalers, and then some, as you see, are given oral or IV medications. Now, we also have drugs for the long-term control of asthma. We can use inhaled corticosteroids, and you see a couple of them listed there. The Flovent, Asthmacort are common ones. Other drugs that have some of their chemical names I've given you here. Inhaled long-acting beta-2 agonists, the leukotriene modifiers, but you know them better as Singulair. Drugs like theophylline, that's a bronchodilator, can be used. And then we can use some of the monoclonal antibodies as well in the management of asthma. Usually patients will be taking some of the long-term meds to keep it under control, and then they'll be getting those short-acting meds when they have an asthma attack.